All right, so now we're going to get into the pathophysiology of musculoskeletal injuries, and this is the meat and potatoes of the actual lecture. And this is obviously the result of blunt or penetrating trauma. Now, you can have a pathologic fracture, which is produced from a force that might not usually cause harm to a normal, healthy bone. And in this case, one of those instances would be maybe a mild fall from standing for a elderly female who then fractures her humerus, right? And so this is obviously caused by medical conditions, and in the example that I've just given you, that would be an elderly female who's gone through menopause, which has caused that hormone imbalance, and now she has osteoporosis. And the upper extremities, just due to the fact that they don't generally have a lot of force applied to them, in most people, the humerus is actually fairly fragile as we get a little bit older, unless you're one of those people that likes to lift a lot of weights and you're putting a lot of pressure and stress through the upper arms. So that becomes kind of a weak point, and when it takes a significant blow that in a younger person would be fine, these will tend to actually create full fractures or complete breaks in the humerus. Now, when we're talking about the mechanism of injury, we're talking about something like a direct blow, and so that's the fractures the bone at the point of impact. And this could be, we'll use violence for this particular instance, and we'll say somebody swings a bat at another person, and the bat impacts the upper arm or maybe even the tib fib, and causes the fracture right at the point of impact. The indirect force is something where we're transmitting that energy up through a bone and it finds the weakest point in the bone. And this, again, you can kind of drive back towards that elderly person who has fallen and then snapped the humerus at basically the humeral neck, right before the humeral head in the shoulder. And that's just because that's a thin point, and that's where it's kind of tried to direct force back out of it. Then we can have that twisting force, which is a common cause of musculoskeletal injury. And this might be kind of like a shearing force as well, where you snap off a transverse process from the vertebra. And this can be fractures, sprains, and dislocations. So now we're kind of talking about a little bit of muscle in the middle of this as well. And then high energy injury. And you can have a high index of suspicion that there's going to be multiple injuries here. And so in this example, I'm going to say somebody jumps off of a house that's maybe 2 stories. They land directly on their heels. You're going to expect that they're going to have some kind of ankle injury. They may have a knee injury, and they may actually have a pelvic injury from the force being applied. And it can actually radiate all the way up into a spinal injury where we've done so much shock and damage that the vertebra smash into each other and cause a fracture in the vertebra. So while we're talking about fractures, we're going to get into the pictures. And as you can see, this looks like 2 legs that have significant fractures. It looks like we have a bone sticking out of one of the actual splits, and these are either closed or open. And as simple as that sounds, it is that simple. Did anything leave the skin or penetrate the skin or not? And if it's closed, that means that we have that break, but we've not actually penetrated or caused an opening in the soft tissue around that particular bone. We call open compound fractures, and again, that's because the break in the overlying skin and the bone has been exposed to the environment or any kind of pathogen or contaminants. Closed fractures, the skin is intact, and that is a simple, or there's several different variations of fractures that can be closed. And now we're looking at some pictures of some closed fractures, and this is where the skin is remaining intact. And there's going to be a lot of swelling and the interstitial pressure from the fluid kind of being driven around that particular fracture. It's not always easy to know whether or not a closed fracture is truly closed, or if there was a small bone shard that may have penetrated and we just haven't actually seen it yet. And so this can be a little bit tricky, but for the most part, it should be fairly obvious. Now, if you're looking at this picture, you can see that there's obvious deformity and angulation to the leg with some additional swelling. And so while this may not have like a true, like the previous picture where the foot is off at a significant angle from the rest of the leg, you can see that this particular person's foot has actually got a little bit of angulation, and it may just have something to do with the outside of the ankle, kind of bringing into question on what actual particular bone is that. Is it a fibula or is it in the metatarsal area? So now we're going to talk about some of these closed fractures, and again, this is the types of fractures that are typically going to be found where something has not penetrated the skin, although any one of these fractures can actually turn into an open fracture. And so you have that simple fracture, which is perpendicular to the line of the bone, and you can see this angulated fracture, and then we get into a spiral fracture where there's kind of a twisting motion where it creates multiple angles of fracture as it spirals down the bone. And then we can get into the comminuted fractures, which you can see small fragments of bone have left, where it might just break off from a condyle or something like along those lines, or where we get that complete fracture through the middle of the long bone and a small chunk of that bone actually breaks away and is now free floating. And then we have that green stick fracture where it's not actually completely through the bone, but it can actually kind of fissure and run the length of the actual bone. And then you can see in the vertebral that compression fracture that we were talking about earlier in the regards of somebody actually maybe having a high speed or high forces directed up through the spine. All right, now we're going to talk about the signs and symptoms of fractures, and this slide kind of gives me a little bit of pain, right? Because the signs and symptoms of fractures should be fairly evident in most cases. Now, I will say that there may be some fractures that are actually, like say a green stick fracture, where we're just going to see a lot of swelling around the area, and we may become confused in regards to whether or not that's actually a fracture or not. And it kind of looks like it's just soft tissue. At the end of the day, any of the fractures that are not really obvious are not going to require a whole lot of splinting because they're being self-supported, and you may actually cause them more discomfort by trying to manipulate them in the event that you think something is got a full break. So take this with a grain of salt. If it looks like it's not in the right place, it's probably not in the right place, and we want to make sure that we splint it in place unless we're absolutely sure that we don't have any kind of blood flow. Otherwise, we really never want to actually kind of manipulate anything that's been angulated or dislocated to the best of our ability. So for the most part, when you see somebody who has significant trauma like that, you're going to get the deformity. It should be shortened because now the bones are not lining up like as its counterpart. There will almost always be immediate swelling. The bruising may not come on right away, but you'll see it within a few hours. They're obviously going to be tender, and they're going to be in significant amounts of pain. And the good thing is the AEMT can actually treat pain. We have several drugs for that, and you guys should always be doing the best you can for your patients. Without the extremity actually having a threat of losing blood supply, typically these patients are going to be a little bit lower on the priorities when it comes to trauma. And so I will encourage everybody, if you have a patient that you can treat for pain and you know that it's going to be a little while before they see an orthopedic surgeon to fix whatever it is that needs fixed, give them the pain management. That is the single biggest help that you can do for somebody other than getting them to definitive care. Now here's where we get into this distracting injury. If you're looking at this, you can see the ankle has opened up and we have an open fracture, and the muscles around the fracture are going to contract because they're going into spasming, and this is actually going to push the bone out of the actual joint or area even more. And the patient is not going to like seeing this. And again, I caution you, because you're not going to see it on a regular basis. Do not become distracted by an injury like you see in this actual picture. This patient needs some pain medication. They're going to get a gross decontamination of the area with some sterile saline. And then you're going to take some saline and moisten up a sterile dressing. You're going to cover this wound and splint and stabilize the best that you can and get them to definitive care. Now, when we're talking about dislocations, dislocations actually happen a little bit more often than when you're going to see something where there's significant trauma. And dislocation means that we have a bone that is displaced from the joint that it resides in. And talking about dislocations, dislocations are when bones are totally displaced from the joint that it resides in. And this typically happens because of a extended range of motion. We've kind of stressed something beyond its normal range of motion, and the ligaments and tendons will allow the bones to slip out of place, and this becomes a very painful injury that a lot of people will experience at some point in their life, be it even just something as simple as a finger all the way up to a hip or a shoulder. If you have a partial dislocation of the joint, the technical term for that is subluxation. And as promised, the finger dislocation in the picture here gives you a good idea. That looks like it's probably fairly painful, and this patient is not going to want to move that finger or extremity. And so pain is going to be very obvious in this, and so anytime the patient goes to move something, it's going to become even more painful. Because the bones are no longer actually sitting in the joint correctly, there's going to be no normal movement. You may have some numbness or some impaired circulation, because as those bones stretch the nerve or create swelling, you're going to increase pressure along the nerve, and when the nerve is reduced in its blood supply, it is going to give up that sensation of numbness or the pins and needles and tingling. This is a fairly urgent injury, but again, if you bring somebody into the ED with a dislocated finger, they're probably not the highest on the list of priorities for actually having that reduced. Now we're going to move away from bones and kind of go back into that soft tissue injury, and we're going to talk about sprains. Sprains are injuries where the ligaments are stretched or torn, and again, this is very common in somebody who has a dislocation, because again, we need the ligaments to keep the bones kind of in line across the joints. And so you may just get something that's been hyperextended and it's not actually dislocated, or you may have torn that ligament. These patients are going to experience tenderness and swelling and the discoloration, or the term ecchymosis again, and the joint will be unstable or exceptionally tender to the touch. They're going to really not want to use this particular body part very often, and unfortunately, ligaments have a very limited blood supply, and so it takes quite a long time for these to heal. Now, when we're talking about strains, this is the muscle injury, and the strain is when we have something that has a excessive stretch or a violent contraction, and oftentimes there's no deformity and there may be some minor swelling. In something that's really significant in the strain, you can actually tear the muscle, where the muscle will actually penetrate the sheath that is, or the fascia that's surrounding the muscle. Now that's something quite a bit more significant, and there are other things to look at in that. You may not see it with the amount of soft tissue that's over the top of this particular muscle, but it is a possibility that in a strain we ultimately end up tearing that fascia or the sheath around the muscle, and that's really kind of a rarity in your day-to-day strain, but it is possible. Now, one of the largest tendons of the body, if not the largest tendon, is the Achilles tendon, and I've actually witnessed this several times where people randomly rupture an Achilles tendon. This usually occurs in athletes that are a little bit older, or in athletes that have a lot of impact to the feet or the heels, or some kind of jumping where there's a sudden stop, right? And so think of gymnasts and things of that nature. Really often you'll see younger female gymnasts that have a large scar where the Achilles tendon is, because they're doing so much high impact to the legs when they're landing and things like that. They tend to experience this injury pretty often in comparison to normal people. The Achilles tendon, unfortunately, is really tough to actually repair, and depending on whether or not this is a complete rupture or just a partial, if it's a partial, for the most part, surgeons are not willing to go in and actually surgically repair this, because the repair can actually impede the ability to actually heal right, and it can actually make things worse. So for the most part, the treatment is pain control, and then a little bit of rehab for several months. And in the last case that I actually witnessed, a friend of mine had a partial rupture of his Achilles tendon, and it took him 10 months to actually heal up to be released back to full duty. Now moving into amputations, and if you recall in the previous injury, we can have what's called an avulsion, and this can be partial or complete. And if it's a complete avulsion, that's the amputation. And so this is the separation of a body part from the remainder of the body. And this could be any one of those things where somebody loses a finger, and it could be a partial amputation where the main section of the finger is perhaps dislocated, or I guess disjointed from the body, and it may actually just be being held on by a small segment of skin that's left there. Now, for the most part, most amputations are obviously life-threatening overall, but a person who perhaps loses a finger is not ultimately looking like they're going to die in front of you while this is happening. The potential for infection and things like that are obviously tremendous. Anytime that you have an amputation, you should be looking for the injury to have also created a fracture, barring that it's a power tool that may have a sharp edge that amputated a digit or something like that. But even in that case, that bone, while not truly fractured, may have been lacerated or cut through itself, which is in the case of like table saws and circular saws removing digits. All right, with any musculoskeletal injury, we have to consider vascular injuries, and one of those injuries is called devascularization, and this is when the blood vessels are damaged following the musculoskeletal injury. Now, think about this as the significant swelling or perhaps the angulation or a laceration through a particular vessel. And these injuries may sustain, as the list says, contusions, lacerations, kinking or bending, or pseudoaneurysms. And that blood vessel may actually cause enough turbulence that the clot will start to form, but not actually attach to anything, and then that becomes that thrombose, or which can ultimately become an embolism.